Hello everyone and welcome to this presentation on knowledge mobilization in the Nigerian context. I am Michel Adje, a physiotherapist from Nigeria and a PhD student in Germany under Professor Carstens. It is notable that over the years, lots have been done to implement evidence-based practice for management of low back pain in Nigeria. However, gaps still exist in terms of practice, especially the psychosocial aspect of care. One reason for this is that Nigeria is a very diverse country with about 500 languages spoken by over 200 million individuals. It presents a unique context for knowledge mobilization for the less than 5,000 physiotherapists practicing in Nigeria. I and my colleagues carried out a contextual inquiry into the perspectives of patients and physiotherapists on strategies to get the best evidence into practice by preparing for the implementation of the start back model of care to low back pain in Nigeria. We carried out a series of telephone interviews with about 20 participants following a set of inclusion criteria. We transcribed the data and thematically analyzed them using the grounded theory methodology. Individuals who participated in this research were 12 males and 8 females, and the mean age was 44. 6 key themes emerged and 49 sub-themes. From the conversations we had with physiotherapists and patients, we discovered that therapists are open to accepting innovation and they continually seek ways to get the best evidence into practice. We can see this from the quote. A physiotherapist said, "Physiotherapists in Nigeria are willing to accept any model of care that make treatment easier. However, they feel that they must first overcome a perceived resistance from the patients, a pushback purportedly fueled by the patient's expectation and also by a prolonged tradition of treatment that the patients have received from their physiotherapist over the years." We see the physiotherapist saying, "Patients will not accept it. They only feel you have done something if you touch them." From the patient's perspective, they had undergone a learning journey. They have gathered lots of experiences from their knowledge of self and also from the treatment they've received both from the clinicians and also from the tradomedical treatment. We see this in a quote. The patient said, "There is a lot in it talking about tradomedical care that complements orthodox medicine. I am able to manage my pain better." Another patient said, "I did not stop church activities. After clapping, moving around, I feel better." This learning that the patients have undergone have resulted in a trust and confidence in the physiotherapist. A patient reported, "I submit myself to him, the physiotherapist. I am there because I am fully confident in him." But when it comes to using this knowledge to influence lifestyle changes, the patients reported needing some form of conviction. As we see, the patient said, "When you are convinced he wants you to get better, then anything he says, you will do it." Our findings also reveal that they are viable facilitators for therapists' use in effective knowledge mobilization. For instance, the sociocultural adaptations. They can modify existing contextual factors like language. We see this in a quote. A physiotherapist said, "If the therapist is the one doing it, he translates it for the patient into local languages." Another viable facilitator is the Afrocentric culture of respect for elders and seniors. This can help in facilitating knowledge. We see a physiotherapist said, "When the chiefs and assistant directors in each unit champion this, then junior physiotherapists will use it." Conclusively, for therapists in Nigeria, Getting the best evidence into practice means making use of existing facilitators. Facilitators like the patient's trust during communication and treatment, sociocultural adaptations like the language and the culture of respect, and also mobilizing knowledge through the professional cadre. Therapists stand a good chance of getting evidence into practice if they work in line with these facilitators. Our findings also show that there is a mismatch between patients and therapists' understanding due to different perspectives. While the therapists see patients' expectation as a major deterrent to knowledge mobilization, patients are often more informed and educated than the therapists realize, and they only need to be convinced. Patients, after all, are experts in their condition, hence the need for patient involvement in knowledge co-production. This knowledge co-produced with patients and physiotherapists in this research will guide the next steps of our project. Strategies here on the best way to get knowledge into practice will be further consolidated and used in tailoring materials for the implementation of the Start Back model of care in Nigeria. I would like to say thank you to our research team. Thank you also to WCPT for this opportunity, and thanks to the audience for watching.